All right, hi, welcome back. It's Andrew Penn with the fifth and final segment to our bipolar spectrum disorders modules. In this last one, we're going to talk about antipsychotics that are available for the management of bipolar disorder. So we'll talk about the different antipsychotics that are indicated for the different phases of bipolar disorder. We'll talk about their effectiveness and think about some of the metabolic risks that they pose and how to monitor for those. We're going to focus primarily on the agents that are helpful for bipolar depression because most all antipsychotics have an indication for bipolar mania. And as I mentioned earlier, that's the low-hanging fruit. What is more difficult to treat is bipolar depression. So, as I said here, here's most of your current atypical antipsychotics. As you can see, with the exception of Lorazeidone and the olanzapine fluoxetine combination, all of them have an FDA indication for bipolar mania. Now, only a handful of them have indication for acute bipolar depression. And I put a note on here that antipsychotics are not broad spectrum psychotropics. I've heard that term batted around a few times, and it always makes me cringe because there's really no substitute for a good diagnosis. Just throwing a sort of all-purpose medication or what is purported to be an all-purpose medication like an atypical antipsychotic is a poor substitute for actually diagnosing a patient correctly. And so you want to use these medications with caution. They're certainly very useful tools, but they should be used with a lot of thoughtfulness. And I also want to point out that there are a couple of the long-acting injectable antipsychotics which are available and have an indication for maintenance phase of bipolar disorder, and that would be the long-acting aripiprazole and long-acting risperidone. So turning our attention first to quetiapine, this is Seroquel. So this is there were two doses that were studied, 300 and a 600 milligram arm. And you can see they overlap in those green and purple lines at the bottom compared to the pink line, which is the placebo. So from this, we can infer that there really isn't an advantage to going higher than about 300 milligrams. Of course, there may be patients for whom that is an exception, but for the most part, 300 milligrams is a reasonable target. In this study, they got there in 4 days, which can be done, especially if somebody is inpatient, but usually as an outpatient, you would probably take a slower pace because quetiapine can be pretty sedating and difficult to tolerate if you dose it that aggressively. But it took about 2 or 3 weeks to start showing a significant difference, and then that benefit carried forward. And a similar subset of patients with bipolar 2, this data was replicated. Now, Lorazeidone or Latuda is another option when it's combined with valproate or lithium. So that's what this study set out to do. So this is a Lorazeidone augmentation study when added to lithium or valproate. And again, you can see the separation begins to happen at about 3 weeks and was superior to placebo. In this particular study. So it was also looked at as, this is Lorazeidone or Latuda, and there's also a monotherapy study that was done. So this is Lorazeidone only, not being added to lithium or valproate. And again, 2 doses were studied, a 20 to 60 milligram range and an 80 to 120 milligram range. And as you can see, there isn't any significant separation between those 2 doses, though both of them were superior to placebo. So a dose of 20 to 60 milligrams of Lorazeidone is a reasonable treatment for bipolar depression and should probably start showing some benefit at about the 2 to 3 week mark, with maximum benefit being seen at about the 6-week mark, which is as far out as this particular study went. Now, what about Cariprazine? Cariprazine, or Vraylar, is the newest drug on the market for this indication. And this is, again, an atypical antipsychotic, fairly potent molecule, usually dosed at 1.5 or 3 milligrams per day. These are 3 different studies that were done which obtained the FDA approval for this drug. And you can see that the drug groups were superior to placebo in all 3 of these particular studies. With some dose response difference in the first 2 studies where the A larger dose did slightly better than the smaller dose, but that was not replicated in the third and final study. So the most common side effects of cariprazine tend to be akathisia and EPS, restlessness, and GI distress in the form of nausea. Quetiapine, when added to lithium or valproate, was studied for maintenance treatment. So this is a survival graph which shows, so at the beginning, at the top left corner, everyone is starting out in remission, and then they are put on either one of these two conditions. So they're either kept on lithium alone, or they are put on quetiapine plus lithium. And you can see that a smaller percentage of people relapsed, which is the red line, on the combination of quetiapine and lithium or valproate versus just the lithium or valproate alone. So this might be a reasonable option for maintenance if the person can tolerate long-term quetiapine dosing. Now, with the atypical antipsychotics, historically, we've had to be very concerned about metabolic risk factors, particularly with what I would call the first generation of atypical antipsychotics. And those are the ones that came out in the early 2000s, such as quetiapine and olanzapine. These often showed significant weight gain, as you can see here. This is just over the course of 10 weeks, an average of 3.5 kilograms. So coming up on about almost 10 pounds of weight gain for people on olanzapine in 10 weeks. That's a lot of weight to gain. And oftentimes this trend line can continue. And I think any clinician who's practiced for a while can tell you stories about patients who gained a lot of weight on these early atypicals. The newer atypicals typically do not have that level of weight gain disturbance, but you still should be monitoring people for increased appetite. And usually if you start seeing more than a pound, I believe if it's a pound per month starting to go on, then you need to get concerned. And sometimes, particularly with olanzapine, for example, people will gain weight very quickly. So I tell people, if you're starting to notice that you have an insatiable appetite, if you're noticing that you are gravitating towards very calorie dense foods such as potato chips or a lot of carbohydrates, I'd like to know about that sooner rather than later so that you don't gain a lot of weight. And we need to be making a good clinical practice of checking weight, blood pressure, waist circumference. So that's done at the umbilicus with a tape measure. You can have a patient do that themselves with a little help from you. And then also getting labs of fasting glucose, lipids, and asking about their family history of cardiovascular disease. All should be done at baseline. And then you want to be keeping an eye on that weight every 4 weeks for the first 3 months, really, and then quarterly thereafter. So have a scale in your office. You should just have a scale in your office and get in the habit of using it. And then you want to recheck blood pressure, waist circumference, glucose, and lipids at the 3-month mark, and then annually thereafter. Just a good habit to get into that. A lot of EMRs will remind you to do this if you haven't done it, but it's just a good habit to get into. Again, when you're refilling medications, just have that be a prompt for you to check the labs. And if you realize it's been a year or so since somebody has had their glucose and lipids checked, go ahead and send them to the lab and order those labs at the same time that you refill the medication. That's an important part of clinical practice. So in closing, I think you've probably absorbed my passion for lithium, and I hope that you keep that in your desert island medicine kit if you were the only provider on a desert island, and also think about adding lithium to lamotrigine or lithium to valproate, and then having a handful of atypical antipsychotics are also very useful in the management of bipolar disorder. And of course, having a benzodiazepine is not a bad idea for managing things like anxiety and insomnia. Here's a few patient resources that I'm fond of. I keep these in my office. Kay Redfield Jamison's autobiography, An Unquiet Mind, is a classic. She's a psychologist who studies bipolar disorder, who also has bipolar disorder, and wrote quite eloquently about her experiences with that condition. David Milkowitz has this wonderful bipolar disorder survival guide, which is very patient-friendly and also patient-family friendly. I'm also a big fan of the Depression Bipolar Support Alliance and the National Alliance for Mental Illness. And for patients that are interested in a more an alternative or even radical way of looking at mental health, the Fireweed Collective is the folks formerly known as the Icarus Project, and is worth taking a look. A few more resources here. The Mood Disorder Questionnaire, which is a screening resource for bipolar disorder, can be found online and free. And there's a few other psychopharm and National Institutes for Mental Health is a good resource for additional information. And finally, Manic Depressive Illness by Goodwin and Jameson is probably the classic text on the subject. So I hope this has been helpful for you. I hope you remember that antipsychotics are effective and useful treatments, but often you want to be careful using them for long-term maintenance unless there's clear data that they are effective in that form, and beware of the potential risks of antipsychotics such as tardive dyskinesia and metabolic disturbance. And the atypical antipsychotics that have good data for bipolar depression would be Lorazeidone, Quetiapine, and Cariprazine, which are, with the exception of Quetiapine, generally fairly metabolically neutral, but you want to keep an eye, of course, on those metabolic measurements for anybody who's on an atypical antipsychotic. So I thank you for your attention, and I hope you found this useful.